I'm Dr. Fakri Robari, and this is urinary tract infections in adults. The basics are so important. Urinary tract infection is the most common bacterial infection in the ambulatory care setting in the United States. Nearly half of females will develop a UTI in their lifetime, with 25% recurrence within 6 months. And over half of all recurrent UTIs are caused by the same initial bacterial strain that caused the first infection. Pyelonephritis is much less common than cystitis, even in patients with untreated cystitis or untreated asymptomatic bacteriuria. Risk factors for UTIs include sexual intercourse, use of spermicides, previous UTI, a new sex partner, and a history of UTI in a first-degree female, because there are some genetic components into it. Now let's take a look at the anatomy of the urinary tract. So on the left you're looking at the urinary anatomy of the females, and on the right you're looking at the urinary anatomy of the males. Note that urethra is what's connected to the bladder, so the urine will actually exit the bladder through urethra in both females and males. So there's urethra that goes through the penis and is connected to the bladder. And the ureters connects the bladder to the kidneys in both female and males. Now in females specifically, the urethra is very close to the rectum. It's very easy for bacterial translocation from the GI. So the GI, so gastrointestinal organisms, can easily translocate to the urethra and then go up to the bladder. So cystitis is much more common in females compared to males. In males, you can see that the opening of the urethra is much further from the rectum. So it's much more difficult for translocation of bacteria from the rectum all the way to the urethra. Also look at the anatomy. So it's much more difficult for bacteria to travel up the urethra in the males. So therefore urinary tract infections are more common in females compared to male. Another thing to note is that in females, when females get urinary tract infections, the bacteria can oftentimes colonize the vagina, and in males, if males get UTIs, the bacteria can also colonize the prostate. So the prostate is also involved oftentimes when a man gets a urinary tract infection. And in men, the bacteria can also cause infection of the urethra. So urethritis is possible, as well as epididymitis. So epididymis is this area that's connected through the prostate to the same pathway. In general, urinary tract infections are divided into two categories. The upper urinary tract infections, which is primarily pyelonephritis. Pyelonephritis is the infection of the kidneys, and the lower urinary tract infection, which includes cystitis, epididymitis, prostatitis, urethritis. So the bottom three are specifically in men, and cystitis can happen in men and women. Let's take a look at the pathogenesis of urinary tract infection. So as I explained on the previous slide, is that bacteria can oftentimes translocate from the gut, specifically from the rectum, and go through the urethra. And then once they go through the urethra, they can colonize the urine in the bladder. This can cause inflammation and an immune response, specifically neutrophils, which can cause epithelial damage leading to the burning sensation in the bladder. Now for most people, this would be the end and their infection will be resolved. However, for some people, the bacteria can ascend even further. So through the ureters, the bacteria can actually ascend all the way up to the kidneys, and they can actually colonize the kidney tissue, resulting in inflammation and damage to the kidney. There are a lot of vasculature in the nephrons, so the bacteria can easily get into the blood, and that could lead to bacteremia or infection in the blood. In general, there are three ways to get urinary tract infection. The first way to get urinary tract infection is through the ascending pathway, which I just described, with the bacteria translocating from the gut to the urethra and ascending to the bladder and then to the kidneys and eventually to the blood. Another way is if the bacteria actually come from the blood. So if somebody has bloodstream infection, because the blood goes through the kidneys, the bacteria can actually go from the blood to the kidneys and then from the kidneys to the bladder, causing cystitis. And the third way of getting urinary tract infection is actually through the lymphatic system. The lymphatic pathway is not as common. In fact, the evidence for it is actually from animal studies. Now let's take a look at reliable resources. IDSA is the Infectious Diseases Society of America. It's the organization in the United States that develops clinical practice guidelines for infectious diseases. The first guideline that you should be aware of is the 2009 IDSA guidelines for catheter-associated urinary tract infections in adults. This is the guideline that clinicians typically refer to for complicated UTIs. The second guideline is the 2010 IDSA guidelines for acute uncomplicated cystitis and pyelonephritis in women. The third one is the 2016 IDSA guidelines for candidiasis. This guideline includes recommendations for candiduria, which is the urinary infection caused by candida, which are fungal infections. You will learn about fungal infections on a different topic. And the last one is the 2019 IDSA guidelines for asymptomatic bacteriuria that were released just a few months ago. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of antibiotics used for UTIs. Let's take a look at some anti-infective agents that are commonly used for the management of UTI. Historically, fluoroquinolones have been frequently used for UTIs. So ciprofloxacin is one of the commonly used fluoroquinolones. The mechanism of action of fluoroquinolones involves inhibition of bacterial DNA synthesis, resulting in rapid bacterial cell death. And this happens by inhibition of two different enzymes. So they can inhibit DNA gyrase, often in gram-negative bacteria. They can also inhibit topoisomerase 4, often in gram-positive bacteria, which results in DNA synthesis interruption. Fluoroquinolones are available as PO and IV for the most part, which can be used for UTIs. Now, there are other formulations, for example, eardrops, eye drops that are not covered in this topic. Fosfomycin is only available as oral in the United States currently, and an IV formulation is under development. And the way it works is that it inhibits MUR-A, which essentially inhibits initial step in bacterial cell wall synthesis. Nitrofurantoin is also only available as an oral option, and there are three proposed mechanisms of actions for it, which include inhibition of ribosomal translation, bacterial DNA damage, or interference with the Krebs cycle or citric acid cycle. Finally, we have the combination of trimethoprim, sulfamethoxazole, which together are available as both oral and IV, which are used commonly for the treatment of UTIs. And the way they work is that sulfonamides inhibit the formation of dihydrofolic acid, and trimethoprim prevents the next step, which would be the synthesis of tetrahydrofolic acid, which in turn inhibits DNA synthesis. Let's take a look at the adverse effects of these antibiotics. Trimethoprim can lead to anemia, leukopenia, thrombocytopenia, hyperkalemia, and hyponatremia. And hyperkalemia is something that occurs in clinical practice often and is something to monitor with patients. Trimethoprim can also inhibit the secretion of serum creatinine in the kidneys, which means that artificially serum creatinine will be increased, but doesn't necessarily mean nephrotoxicity. Sulfamethoxazole, however, can cause nephrotoxicity. So because these two come together, so together this combination is considered nephrotoxic. And sulfamethoxazole, which is a sulfa drug, that component can cause rash, photosensitivity. It can also cause GI upset like nausea, vomiting, diarrhea, as well as hepatitis, anemia, thrombocytopenia. And it is recommended that the patients actually take this combination with at least 8 fluid ounces of water in order to avoid formation of crystals in the kidneys, in order to avoid or at least reduce the risk of nephrotoxicity. It is also advised for the patients to use sunscreen and avoid tanning beds because of the photosensitivity. Nitrofurantoin can also cause GI disturbances as well as CNS effects, such as headache and drowsiness. It can also lead to allergic reactions that often present as leukopenia, granulocytopenia, eosinophilia, and hemolytic anemia. And hemolytic anemia is often present in people with glucose 6-phosphate dehydrogenase deficiency. It can also cause peripheral neuropathy, interstitial pneumonitis, and it can also make the urine color change to brownish color. And with chronic use, it can also cause pulmonary fibrosis. Lastly, it can cause hyperkalemia. It is recommended that nitrofurantoin be taken with food to improve absorption and avoid concurrent magnesium products, which can reduce the absorption. Phosphomycin is currently available as oral, and it comes in packets that include powder, and the patients need to mix it with 3 to 4 fluid ounces of cool water, so it should not be done in hot water. And it can cause diarrhea, nausea, headache, vaginitis, as well as dizziness, abdominal pain, as well as rash. Now, a lot of bad things happen with fluoroquinolones in general. So let's focus on ciprofloxacin. So with ciprofloxacin, like many antibiotics, GI disturbances can occur. So nausea, vomiting, diarrhea, abdominal pain. But with fluoroquinolones, you can also have CNS effects like headache, dizziness, hallucination, delirium, and in some cases, seizures have happened, including in patients who had underlying neurological disorders, and also like patients who were taking NSAIDs. So NSAIDs can increase the risk of having seizures with fluoroquinolones. There's also been reports of peripheral neuropathy that may be irreversible, as well as arthralgia and joint pain, tendon rupture or tendinitis, and these basically occur mostly in elderly patients over the age of 60. They are at high risk. Fluoroquinolones can also lead to QTc prolongation. Now, ciprofloxacin has the lowest risk compared to other fluoroquinolones, but the risk still exists. It can also cause rash and photosensitivity. It is recommended that patients avoid taking any dairy products, so anything that includes a cation such as calcium should be avoided, so they should be separated by at least 2 hours. And just as in any product that causes photosensitivity, patients should use sunscreen and avoid tanning beds and avoid excessive exposure to sunlight.
Here are the formulation for nitrofurantoin. So back in 1952, when we first came up with nitrofurantoin, it was in macrocrystalline formulation. It had really good absorption, but it also had increased GI effects, adverse effects, which led us to developing a macrocrystalline formulation. This improved the GI adverse effect, but the absorption wasn't as good. So that's why with macrocrystalline, we have to dose it 4 times a day because it's not absorbed, so you have to do it multiple times throughout the day. Until later, we actually, when we develop macrobed, that's a combination of macrocrystalline and macrocrystalline, so improves absorption and also improves GI adverse effects, and this is dosed twice a day, so 100 milligram 2 times a day. And here's the spectrum of coverage of nitrofurantoin and phosphomycin. So they do cover enterococcus, which you would suspect in UTIs, as well as VREs. They also cover VRE, and also they have good coverage for E. coli. So that's why these two are excellent agents to use in cystitis, and resistance rate has not increased over the years. Because there are different formulations of nitrofurantoin, and if you're working with the generic, it just says nitrofurantoin on it. So it's important to be able, as pharmacists, to distinguish between the two formulations. So as you can see, choice A, it actually tells you that this is monohydrate macrocrystals combination, whereas the second is just macrocrystals. So this question is which is the generic for macrobid. The correct answer would be A. It also tells you here, so A is macrobid. It says that it's dosed twice a day, take it with food. Whereas the second option, it tells you, let's see, QID, so 4 times a day with food. So that's how you know choice A is macrobid. So as pharmacists, you should be aware of, if the doctor wrote for macrobid, don't dispense the second option, especially if the instruction says take one pill twice a day. You do not want to give them this because it's not going to be absorbed as much and you're going to have failure, treatment failure.
Now let's take a look at sulfonamide allergy, which is often referred to as sulfa allergy. Now about 3 to 8% of patients report experience with sulfonamide allergies, and in general all sulfonamides, which can be divided in sulfonamide antibiotics and sulfonamide non-antibiotic agents, they basically all contain a sulfa moiety. And then sulfonamide antibiotics also contain additional substitutions at N1 and N4 positions. And the evidence currently suggests that these substitutions at N1 and N4 are the primary determinants of drug allergy instead of the common sulfonamide moiety. So based on the evidence that's available currently, there is a very low risk of cross-allergenicity between sulfonamide antibiotics and non-antibiotic agents. So when you hear a patient have a sulfa allergy, you should determine if it was due to a antibiotics sulfonamide or a non-antibiotic sulfonamide. And in general, sulfonamide non-antibiotic agents include loop diuretics like furosemide, thiazide diuretics, so hydrochlorothiazide for example, sulfonylureas, triptans that are used for migraine, acetazolamide, celecoxib, which is a COX-2 inhibitor, as well as some protease inhibitors for HIV, such as darunavir. And sulfonamide antibiotics, for the most part, include sulfamethoxazole, which we use for UTIs in combination with trimethoprim, but there's also sulfadiazine as well as sulfasalazine. So rechallenge and desensitization strategies may be appropriate for patients with sulfonamide allergy with delayed maculopapular eruptions, but alternative treatment options are more appropriate for patients with severe infections. Identify signs and symptoms of cystitis and pyelonephritis. Let's take a look at some key definitions. When you get a urine sample from a patient, for most individuals there will be no bacteria in the urine. The urine is supposed to be sterile, especially in men, and we call this sterile urine. Now, if you find bacteria in the urine sample, this could be due to contamination of the sample. This could be from the skin of the patient or from the environment. Once you rule out contamination, if there are bacteria in the urine, we call this bacteriuria. This means the presence of bacteria in the urine. If a patient with bacteriuria has no symptoms, we call this asymptomatic bacteriuria. This is not a urinary infection and does not need to be treated in most patients. If the patient does have symptoms, however, we call this symptomatic bacteriuria, or more commonly known as urinary tract infections. What exactly are these symptoms? The four most common symptoms are frequency, so the patient has to urinate small amounts frequently, and it will be painful, which we call dysuria. There will also be urgency, or the urge to void immediately, and there can also be hematuria, or the presence of blood in the urine. As I mentioned earlier, there are different types of UTIs. The most common one is cystitis, or the infection of the bladder. There is also pyelonephritis, which is not as common but is very important. Symptoms that are more specific to pyelonephritis include fever, which is not always present, but if it is suggestive of pyelonephritis. There will also be CVA tenderness or flank pain. CVA tenderness is detected during physical exam, typically by a physician as they tap on the back of the kidneys with their fingers. UTIs can also be considered uncomplicated or complicated. For example, there's uncomplicated cystitis or there is complicated cystitis. Let's take a closer look.
So uncomplicated UTI refers to infection in a structurally and neurologically normal urinary tract. And this is important because if you have a normal urinary tract, both anatomically and neurologically, that means you have normal flow of the urine, which typically clears the tract. So there's no, even if there are occasionally bacteria, the urine flow will actually wash them out. We also have we don't have guidelines for complicated UTI, but here's the generally accepted definition for it. It's basically a UTI in the presence of factors that predispose patients to persistent or relapsing infection. So these include if the patient has foreign bodies. Most important one is indwelling catheters. Also, if the patient has obstructions, immunosuppression, renal failure, renal transplantation, and urinary retention from neurologic disease. These are, risk factors that basically disrupt the normal flow of the urine, which is supposed to clear the bacteria out and maintain a sterile urine. In addition, infection in men, pregnant women, and children are also considered by most experts complicated UTI. And the reason we try to distinguish complicated UTI is because these infections typically are due to, or I should say, they are more likely to be due to resistant organisms. So having that in mind, it helps selecting antimicrobials when treating complicated UTIs.
We identified signs and symptoms of cystitis and pyelonephritis. Now the next learning objective is distinguish between bacteriuria, sterile pyuria, and sterile urine using the results of a urinalysis or a UA.
Now here's some definitions of different types of collection techniques for the urine specimen, and this is just for this slide is just for your information. So voided urine or random specimen. This is basically the most commonly used method by most labs. So this is basically where a cup is given to the patient and they basically urinate in it. So it's very important for the patient to not contaminate the sample. So it's important for them to not touch it. And, as you can see, as you can imagine, it would be possible, as the urine is coming out, it could basically pick up bacteria from the skin. So it's possible that it could be contaminated, but this is easy and most commonly used. Another method is midstream clean catch urine, so most commonly referred to as clean catch. The reason this is preferred, but it's not as easy, is because this is less likely to be contaminated. So basically the patients are actually required to cleanse the area first, and then they're going to void the first portion of the urine into the toilet, and then the remaining urine into the cup. That way, hopefully, the urine is less likely to pick up bacteria from the skin as the urine comes out. The next method is catheterized urine. So this is basically done in patients who have a Foley catheter in place. So this is common in the hospital, especially a lot of the patients in the hospital already have a Foley catheter in place for various reasons. So if so, you can easily collect the urine and avoid any contamination. And there's also suprapubic aspirate. This is basically a needle is used to go directly into the bladder and pull urine out. So it's not as commonly used, but occasionally if there's obstruction and the patient is unable to actually urinate, and there's but the kidneys work and the urine is being produced, we can actually go directly into the bladder and draw the urine out. I know sometimes this is done just to get rid of the urine. And sometimes it's also done to get the sample to send to the microbiology lab. So here's what happens in the micro lab. So urinalysis is the easiest thing you can do, is the cheapest thing we can do, and it's the most commonly done thing in the hospital. So once you get your urine sample, and it comes to the micro lab, the first thing they do, they have these strips for urinalysis. So they have these strips are they have different sections on it, and what they do is that it's basically a dipstick. So they just dip it into the urine, and as the color of different sections change, they basically interpret it based on the color. So this is immediate. So as they dip it into the urine, the colors change and they can see it. So you get the results the same day that the urine sample is sent to the micro lab. And you don't need to memorize this or anything. It's just for your information. But basically, there are, based on the color, they will tell you, the results of the UA or urinalysis. So I'll give you one example. So for example, one thing that they look for is the presence of nitrite. So there's a section on this on the strip for nitrite. So basically, they just see how the color changed, and they will tell you if it's negative or kind of positive, and then definitely positive. And you can do this for other things. For example, if they wanted to see if there's glucose present, if it's yellow for this particular test, they would say it's normal, and so on. So here's what you really need to know. So once the results of the urinalysis is reported, you need to be able to interpret it. So a normal urine, it's supposed to be clear and yellow. So if you find it to be cloudy, it can be due to different reasons. Either there's an infection, or especially in patients who have kidney disease, because there's damage to the kidney and things that are not supposed to be there find their ways into the urine, such as protein or any other chemical from the body, it will make it look cloudy. So cloudy doesn't necessarily mean infection, but it could. Another thing that's important to look at is the presence of nitrite and leukocyte esterase. So if nitrite is not supposed to be there in the urine, so if you do find nitrite in the urine, it could suggest the presence of bacteria. Now, if the nitrite is not there, doesn't necessarily mean that there is no infection, and I'll explain that more on the next slide. If you find leukocyte esterase, that means there white blood cells are present, because these esterases are released from the actual white blood cell from the body. So if you do find the leukocyte esterase, that just means that there are white blood cells present, and we call this pyuria. So pyuria means the presence of pus in the urine, or more specifically, the presence of white blood cells or leukocytes in the urine. And you can actually measure how much white blood cell is in the urine. So the exact definition of pyuria would be if you have white blood cell of more than 10, then we call this pyuria. Of course, you can also see if there are bacteria in the urine. So the presence of bacteria, we call this bacteriuria. However, note that in a urinalysis, if you do find bacteria, this could be due to contamination. So this may not necessarily be bacteriuria, it could be just contamination. And the way that we check for contamination is that we look at epithelial cells. So epithelial cells are from the skin, so you shouldn't have it in the urine. So if you do find significant amount of epithelial cells in the urine, that means they're coming from the skin, which means that your sample is contaminated. So if you do find bacteria and epithelial cells significantly, you have two options. Either you really have bacteriuria in the patient and also it got contaminated, or the patient doesn't really have bacteriuria, but it got contaminated. And the only way to distinguish that is by actually doing a urine culture and see if we can grow actual bacteria. But epithelial cell is what you look for to see if the sample is contaminated. And then if you have casts, there are different types of casts that are used to assess kidney function. If the patient has pyelonephritis can also cause some damage to the kidney, which kind of explains why you will see casts. So if you do find casts in the UA, doesn't necessarily mean pyelonephritis. It could mean either the patient has AKI or CKD, or it could be pyelonephritis. So these are things that are used in combination when you do patient assessment. So for example, if the patient normally has if the patient doesn't have a history of kidney disease, but suddenly comes to the hospital with fever and flank pain, and you see casts on the UA, that could suggest that the patient could possibly have pyelonephritis, and the physician will do further imaging to confirm the diagnosis. Let's see what else I didn't talk about. Oh, the pH. Some organisms such as Proteus mirabilis are capable of splitting urea, which will increase pH. So occasionally you will see that the pH will be higher than the normal range. And that kind of helps you suspect Proteus mirabilis, so when you choose antimicrobial agents. Okay, so bacteriuria I talked about, sterile pyuria. Sometimes you will not have bacteria in the urine, but you will see white blood cell increase. That's what they refer to as sterile pyuria. So pyuria, that means pus is present, white blood cell. So there's some sort of infection going on, but it's sterile because you didn't see any bacteria. So this can be due to different reasons, but one would be, for example, if a patient has a viral infection, you will still get a white blood cell response, but there will be no bacteria. So that's just important to know, because if you get sterile pyuria, sure, the patient has some sort of infection, but you don't need antibiotics to treat it because you didn't see bacteria. And of course, you would like the urine to be, you would like to see sterile urine in most patients, and it's important to rule out contamination. So here's the nitrate cycle. So basically, nitrates are important. As you eat food, nitrate will be part of the food that comes into the body, and of course, the bacteria that are part of the flora will use nitrate, as food. And this cycle continues. However, by the time it makes it back to the urine, you will still have nitrate. So nitrate goes back and forth by bacteria. Bacteria will convert nitrate to nitrite, but the end product that goes actually to the kidneys is nitrate itself. So nitrate comes from the food and also is excreted to the urine. So by the time it goes to the urine, you should only see nitrate. And what we check on urinalysis is nitrite. So because you are only supposed to have nitrate in the urine and not nitrite, and you're not really supposed to have bacteria in the urine, if you do find nitrite in the urine, that could suggest that there are nitrate reducing bacteria in the urine that are converting the nitrate, which is supposed to be there, into nitrite. So that's why we check for nitrite. If we detect it, you suspect that there are bacteria converting the nitrate in the urine to nitrite. And there are nitrate reducing bacteria such as Enterobacteriaceae. So most common member of Enterobacteriaceae family is E. coli, and also Pseudomonas. So that's what we suspect. Now, the reason I mentioned earlier that if you do not find nitrite in the urine doesn't necessarily mean that there are no bacteria is because if you have too much of these bacteria, once they run out of nitrates, then they start to use nitrite as food and convert it to ammonia. So if you have too much bacteria, then nitrite, they will use all of the nitrite. So when you do your test, then nitrite shows up negative. So that's why if it's positive, it suggests there are bacteria. But if it's negative, doesn't necessarily mean that there are no bacteria. Of course, if you don't have bacteria, nitrite would be negative. But if you have too much of nitrate-reducing bacteria, you will also not see nitrite. To make it more complicated, there are also non-nitrate-reducing bacteria. So if you have any of these in the urine, they're not going to touch the nitrate, so your nitrite will be negative again. So it's not a perfect test. If nitrite is positive, it suggests that there are bacteria, but if it's negative, you need to keep looking.
We looked at signs and symptoms of cystitis and pyelonephritis. We distinguished between bacteriuria, sterile pyuria, and sterile urine using the results of a UA. Now the next learning objective is ensure urine cultures are taken in patients with pyelonephritis or recurrent cystitis.
Okay, so here's the severity of urinary tract infections. So it goes from less severe to more severe. So note that cystitis is all the way to the left. So cystitis in general is a benign infection. If you don't treat it, it may actually resolve on its own, or it's possible that it can actually progress to pyelonephritis. Pyelonephritis, however, is a severe infection. Keep in mind that by the time it's pyelonephritis, it has actually infected the kidneys by now. And it can actually progress to bacteremia, and that's assuming, if it's an ascending infection. So if the bacteria are actually coming from the bladder, so it's ascending, it's going up to the kidneys, and then the next step is to go into the blood, causing bacteremia. The other way to get it is actually the descending pathway. So if someone has bacteremia, the bacteria can come from the blood and go to the kidneys and cause pyelonephritis. So for pyelonephritis, we do need urine and sometimes blood cultures. And when I say sometimes, if someone suspects that it's already made it to the blood, that's when you're gonna need blood cultures. But you definitely need urine cultures to treat pyelonephritis. And then, of course, the very severe infection is urosepsis. Urosepsis basically means sepsis caused by UTIs. For urosepsis, both the urine and blood cultures are needed. So note that the reason we always get blood cultures is, this is an extremely severe infection. Patients, in fact, need to be admitted to the hospital because this is an emergency and it can lead to death. That's how severe this is if it's not, managed appropriately. So this is, definitely patients need to be in the hospital. Whereas for cystitis, because it's a benign infection, the patients do not need to go to the hospital. They can be treated outpatient. So typically patients end up going to their primary care physician. A lot of patients who get multiple cystitis throughout the year, they can actually get treatment over the phone. So if you already have a primary care physician established, sometimes you can call your doctor and the doctor will send a prescription to your pharmacy. Or sometimes the doctor can actually, if you already have established primary care physician and they know that you get or the patient gets cystitis like 4 or 6 times a year, they can actually give antibiotics ahead of time, and then the patient can go ahead and take the antibiotics as they get cystitis. Because it's, for someone who gets cystitis multiple times, it's easy for them to identify the symptoms. And it also eliminates unnecessary costs of going to the doctors, for a benign infection. Especially, it will eliminate patients going to the emergency department. And then, of course, in the middle we have pyelonephritis, which is a severe infection, but it's not really an emergency. So it's recommended that patients should go to the urgent care clinic. So, urgent care clinics are, typically open 24 hours. So, patients typically end up going to the emergency department because, a lot of people are not aware that there are urgent care clinics. And that can actually reduce the cost because going to the emergency department is very expensive and it should be reserved for very severe infections. But the reason pyelonephritis needs to go, patients need to go to the urgent care clinic rather than outpatient is because urine cultures are needed. So, it's not something that the doctor can do in the office or over the phone. So at least the patient needs to go to the urgent care clinic and potentially to the hospital if needed. So who exactly needs urine cultures? So as I mentioned, pyelonephritis is a severe infection and cultures are needed to ensure appropriate treatment is selected. Urine culture is not needed for cystitis. It is needed for recurrent cystitis. And the reason is if someone keeps getting cystitis, it's likely to be due to resistant organisms. So for that reason, we need cultures to identify susceptible antimicrobial agents to make sure we treat it appropriately. And of course, complicated UTIs are also more likely to be due to resistant organism, and that's why we also need urine cultures to make sure we use agents that are susceptible.
We explored signs and symptoms of cystitis and pyelonephritis. We looked at the results of your urinalysis to distinguish between bacteriuria, sterile pyuria, and sterile urine. We ensured urine cultures are taken in patients with pyelonephritis or recurrent cystitis. Now, the next learning objective is list the top 4 common uropathogens that cause urinary tract infections.
So here on the left, I have uncomplicated UTI, which is the focus of this topic, and this could be cystitis or pyelonephritis. But as you can see, the number one organism that causes these uncomplicated UTIs is E. coli. So E. coli is the #1 organism. You should always cover for E. coli. So whatever agent you choose, you need to make sure that it has a good coverage for E. coli. And then outside of that, you have Klebsiella pneumoniae causing a lot of these infections, and also Staphylococcus saprophyticus, as well as Enterococcus. So these are your top 4 organisms that commonly cause urinary tract infections. Now, note that like other organisms can cause UTIs, but they're not as common. So Pseudomonas, for example, Pseudomonas aeruginosa, there's about like 1% case. So you don't really cover, you don't need agents that cover Pseudomonas for every patient. Occasionally, by occasionally I mean like there's like 1% chance that they may need it, and by then, we will have cultures and basically, if that 1% shows up, is when your antibiotic is not working, and then we get cultures, and then you find Pseudomonas. But you do not want to cover for Pseudomonas for every patient with UTI. You want to target the top 4. And of course, when it comes to complicated UTI, you start to, still E. coli is your #1 organism, along with Klebsiella and Enterococcus. However, note that in complicated UTI, you do start to see more of Candida species causing UTI due to Candida, or Candiduria as we call it. Now, I know, so in complicated UTI, they are more likely to be due to resistant organism. So, for example, look at Pseudomonas. So Pseudomonas are more likely to cause complicated UTI, but still is around 2%. So it's still something that you do not want to cover empirically for everyone. So you do not need to cover for Pseudomonas for patients with complicated UTI. If you happen to find it on the urine culture, that's when we cover, we use an agent to treat it. Otherwise, empirically, we target the majority. So you need to target the top 4, and in this case, also Candida, when we talk about complicated UTI. But I want you guys to focus on uncomplicated UTI. So just know these top 4 agents cause uncomplicated UTI.
We identified signs and symptoms of cystitis and pyelonephritis. We analyzed the results of a urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis, and we looked at the common uropathogens. Now, the next learning objective is, given a patient case, recommend effective drug therapy for treatment of cystitis or pyelonephritis.
The IDSA guidelines recommendations for treatment of uncomplicated cystitis. Here's what they say. So they say fluoroquinolones should not be used as first-line agents for cystitis, and that's because of the high propensity of collateral damage, and that's because fluoroquinolones are very broad. So ciprofloxacin and levofloxacin cover Pseudomonas. So if you're not trying to cover for Pseudomonas, you do not need to use a drug that covers Pseudomonas, because that will lead to collateral damage. It will cause ecological changes in the flora in the patient. PO beta lactams have low efficacy in general, so they should be reserved as last line. Especially amoxicillin and ampicillin have been shown to have poor efficacy. But if you do, for example, if someone has allergy to our first line agents and you have no choice but to use PO beta lactams, your options are amoxicillin, clavulanic acid, cefdinir, cefaclor, and cefpodoxime. But they should be reserved as last line. The IDSA recommends trimethoprim sulfamethoxazole, or trimsulfa, as first line option, but they do say that you should not use it if the resistance rate is more than 20%. And these guidelines were published in 2011, and since then we know that the resistance rate is actually more than 20% across the United States. So you should not use Bactrim or Trimsulfa for cystitis empirically. And the reason I say you should not use it is because in cystitis we do not get the urine cultures. So if you do not get urine cultures, there's no way to know if E. coli is susceptible to Trimsulfa. and because the resistance rate is more than 20%, you have more than 20% chance of failing treatment. So that's why you should not use trim-sulfa. Which means that we are left with two agents. So here are the two agents that are recommended first line by IDSA. So nitrofurantoin and fosfomycin. Now note that fosfomycin, you will give 3 grams PO just one time. So it's just a one dose and you're done with treatment. So that's very convenient. And nitrofurantoin, you have to treat for 5 days. So this is exactly why you do not need to get cultures for cystitis, because it typically takes at least 3 days to get the culture results back. So if you gave the patient fosfomycin, you're done with treatment. So what are you going to do with the culture? And if you're using nitrofurantoin, by the time you get the culture results back, you're on day 4. So it's just one more day left. So what are you gonna do with that urine culture? You're almost done with treatment. So there's no need for urine cultures in cystitis. And here are your two options. Now note that with nitrofurantoin, if someone's renal function doesn't work well, so if creatine clearance is less than, if the kidneys don't work well and creatine clearance is less than 60, it's basically contraindicated. And if fosfomycin is not available, or if it's too expensive, it's actually not that expensive. It might be like $40, $30 or $40. But if somebody couldn't pay for it and nitrofurantoin is contraindicated, that's when you are left with PO beta lactams. Like you go to cefpodoxime, for example. But if you can use these two, that's what you want to do because of the increased efficacy. PO beta lactams have inferior efficacy, but they'll work. You're more likely to get recurrent cystitis if you use PO beta lactams as opposed to these two agents. Now, a lot of doctors, of course, like to use ciprofloxacin because it's PO, but it's our job to remind them of the collateral damage of ciprofloxacin, and they should not use ciprofloxacin. Unless you had to. So if a patient had contraindication to nitrofurantoin and fosfomycin wasn't available, and they also had beta lactam allergy, and then sure, eventually if you have nothing else left, you can use ciprofloxacin. But when you have these options available, you should not use fluoroquinolones. Now for pyelonephritis, again the same goes for Bactrim or trim-sulfa. Empirically, you should not use it because resistance rate is more than 20% across the US. But if you get your culture results back and it says that it is susceptible to trimethoprim sulfamethoxazole, then you can use it, but not empirically. Also with fluoroquinolones, empirically you should not use them because resistance rate is more than 10%. The threshold for fluoroquinolones is 10%. The threshold for trim-sulfa is 20%. So empirically, you should not use ciprofloxacin. But once your culture results come back, you could potentially use it, but it's not first line again because of collateral damage. Now, in pyelonephritis, you should have urine culture, so that helps us. Whatever you chose empirically, we're gonna, once you get the culture and susceptibility results back, we're gonna use directed therapy. So, which means that, because empirically you cannot use fluoroquinolones and you cannot use trim-sulfa, what you can use is third generation cephalosporins. So, ceftriaxone is the #1 agents that you will see used until the culture results are back, and then you can de-escalate from ceftriaxone to something more narrow. Now here's the resistance. So let's take a look at the changes in resistance rate of E. coli across the United States. So here we're looking at 3 different agents. So nitrofurantoin, trim-sulfa, and ciprofloxacin. They have also separated it by age groups. So elderly, ages of 65 years or older, and younger. And then, so they're comparing the the rate was in 2003 and what the rate was in 2012. And this was published in 2016. So it takes a few years to collect all this data and get it published. So that's why goes up to 2012. So when you look at nitrofurantoin, you can see that there wasn't much difference. There was basically no significant increase in resistant rate between 2003 and 2012. So that's why nitrofurantoin is a really good agent to use empirically. When you look at the trim-sulfa, you can see that in 2012, for both age groups, the resistance rate is more than 20%, which is more than the threshold that the IDSA recommends. So that's why trim-sulfa should not be used empirically. The same goes for ciprofloxacin. In 2012, the threshold is 10%, so definitely over 10% for both age groups. That's why Cipro and Bactrim should not be used empirically. Nitrofurantoin can be used empirically for cystitis only.
So we looked at symptoms of cystitis and pyelonephritis. We analyzed the results of urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis. We also recommended effective drug therapy for treatment of cystitis and pyelonephritis. Now, the next learning objective is change empiric therapy to pathogen-directed therapy based on urine cultures and susceptibility results. The concept of collateral damage refers to unintended ecological adverse effects of antibiotic therapies, and this includes selection of drug-resistant organisms as well as unwanted development of colonization or even infection with multi-drug resistant organisms. Here's how selective pressure works. The normal flora includes a diverse population of bacteria, and this diversity is beneficial for health because these organisms can actually compete with pathogenic bacteria for growth. So they actually prohibit the growth of pathogens. Although these bacteria are beneficial for health, some of them could actually include genes for resistance. So imagine these two strains of bacteria that are pink, they actually include genes for resistance. Although they are resistant to antibiotics, they are not really causing any infection or any problems in the host. Now imagine that you start using antibiotics for an infection. While the antibiotic is important for killing the infection, the antibiotic can also kill all these beneficial flora. And when it happens, all the flora that are susceptible to the antibiotic will die, except those beneficial bacteria that were resistant. And because those resistant bacteria, although they are not causing any problem, because they stay around, they actually become the dominant species as part of the flora. And now, the majority of the flora include genes for resistance. And then when the day comes when an actual pathogen invades the host and causes infection, these flora can actually transfer those resistant genes to the pathogenic bacteria from plasmids and cause infections that are resistant to antibiotic. And this is referred to as selective pressure, where the resistant organism becomes the dominant species. This selective pressure is greatest with broadest antibiotics, and the risk is lowest with narrowest antibiotics. So therefore it is important to keep that in mind, and when we select antimicrobial agents for our patients, to choose the narrowest possible option. This chart here is one way of thinking of broad versus narrow spectrum of activity. And this broad versus narrow is specifically based on the propensity of these antibiotics to cause collateral damage. So tier 1, which is the narrowest antibiotics, includes the urinary agents. So nitrofurantoin and fosfomycin, because they primarily go into the urine and they don't go anywhere else in the body, they don't have the propensity to cause collateral damage. So for example, they do not affect the normal flora in the gut. The same is true with penicillin, because penicillin does not have activity against most organisms. Tier 2 includes first generation cephalosporins such as cefazolin. It also includes ampicillin and trimethoprim sulfamethoxazole or Bactrim. So tier 2 is more likely to cause collateral damage compared to tier 1. Now tier 3 includes third generation cephalosporins, ceftriaxone, as well as antibiotics that cover anaerobic organisms such as ampicillin, sulbactam, and amoxicillin clavulanic acid. So tier 3 is more likely to cause collateral damage and infections due to Clostridioides difficile compared to tier 2 and tier 1. And tier 4, which includes ertapenem. Ertapenem is a carbapenem that's actually the narrowest carbapenem available, and it's typically reserved for ESBL infections. Now, starting at tier 5, these are very broad antibiotics because now tier 5 actually has activity against Pseudomonas. So really tier 5 is when people start to talk about broad spectrum antibiotics. So cefepime, ceftazidime, piperacillin, tazobactam, ciprofloxacin, levofloxacin, gentamicin, and tobramycin, they all have activities against Pseudomonas. So these should be reserved for infections where you suspect Pseudomonas. So if you are not treating or if you are not suspecting Pseudomonas, you should not be using tier 5 and higher because the propensity for collateral damage and selecting for resistance is greatest from tier 5 and up. Now tier 6, which includes carbapenems such as meropenem as well as ceftolozane, tazobactam. These are active against multi-drug resistant Pseudomonas, so they should be reserved for multi-drug resistant Pseudomonas. Meropenem is also used for ESBL producing Enterobacteriaceae as well as ertapenem because ertapenem and meropenem are carbapenems, and carbapenems are typically drugs of choice for ESBL producing Enterobacteriaceae. And of course, the last tier, which is the broadest, it's actually agents that are active against carbapenem-resistant Enterobacteriaceae. So when carbapenems don't work, these are the options. So these should be reserved as a last resort. Another thing to keep in mind when selecting agents for treating urinary tract infection is penetration to the site of infection. Nitrofurantoin and oral phosphomycin are excellent for cystitis. However, neither of them stay in the renal tissue, so they go straight into the bladder. They don't. So they go completely into the bladder. They don't stay in the renal tissue. So therefore, nitrofurantoin and phosphomycin, specifically oral phosphomycin, should not be used for pyelonephritis. Moxifloxacin also does not go into the bladder, so moxifloxacin should not be used for cystitis. In this table, I'm showing you the percentage of different antibiotics that actually get excreted renally, as well as some antifungals. What I want you to know from this table are the bolded agents, and not necessarily the percentage, but the fact that these bolded agents get enough concentration in the urine. Majority of cases of uncomplicated UTIs include cystitis, so nitrofurantoin, 5 days of treatment is adequate. With phosphomycin, total duration of therapy is just a single dose. Now these are in most cases. For example, if someone has ESBL UTI, a single dose of phosphomycin may not be adequate. For pyelonephritis with IV beta-lactams, total duration is 7 days. The same is true with fluoroquinolones, whether it's IV or PO.
And that would be 7 days total. So let's say if someone got IV beta-lactam for the first 3 days, and then they were switched to a fluoroquinolone, then they just do 4 more days of fluoroquinolones with plus the 3 days of IV beta-lactam to give you a total 7 days.
With Bactrim, 14 days is required, as well as PO beta-lactams. So because PO beta-lactams are inferior to IV beta-lactams, you need 14 days of treatment, and PO beta-lactams are last option.
Let's say if someone got 3 days of IV beta-lactam, then they get 11 days of trim sulfa to complete 14 days of treatment.
With complicated pyelonephritis, we do not have clinical practice guidelines. So in general, most clinicians agree on 7 to 14 days of treatment. However, there is clinical evidence that 7 days of treatment is sufficient for most patients with complicated pyelonephritis. So I would recommend 7 days of treatment for complicated pyelonephritis.
So let's take a look at the case study. So let's say CR is a 50-year-old woman with no significant past medical history and no known drug allergies, who is being treated empirically for pyelonephritis with ceftriaxone 1 gram IV every 24 hours. So let's say today is day 4 of treatment, and she's clinically well, here's the results of the urine culture. So the organism is E. coli, and the susceptibility results have come back. So basically, R means resistant. So amoxicillin clavulanic acid is resistant. Ampicillin sulbactam is resistant. Cefpodoxime is susceptible. Ceftriaxone is susceptible. Ciprofloxacin is resistant, and trimsulfa is susceptible. So what would you use? So far it's been ceftriaxone. Ceftriaxone is IV, and at some point, if the patient is ready to go home, we can change this to PO. So ceftriaxone only is available as IV. So but first of all, you want something that's susceptible. You don't want to use something that's resistant. So augmentin, for example, is PO, but because it's resistant, we're not going to be able to use it. So from the things that are susceptible, trimsulfa is available PO, and so is cefpodoxime. Cefpodoxime is a third generation cephalosporin that's available as PO, so you have two options left. So between the two, the correct answer would be Bactrum, because PO beta lactams don't get enough concentration in the urine. So if you do have options, PO beta lactams should be your last option. So for example, if this patient happened to have sulfa allergy, then trimsulfa would not be an option, and then you can use cefpodoxime. But since this patient does not have sulfa allergy, we would go ahead and choose Bactrum, or trimsulfa would be the best option.
The last learning objective is to describe how over-the-counter products should be used in the treatment and prevention of urinary tract infections.
Now, so we have this cranberry juice or tablet over the counter. So you will see the brand name Azo Cranberry in most pharmacies. And the theory behind it is that it may inhibit adherence of uropathogens to urinary tract surfaces. So this is a prevention rather than treatment. So if you can prevent the adherence of uropathogen, then perhaps maybe you could prevent UTIs. There's limited clinical data for this. In fact, in 2013, JAMA Clinical Evidence Synopsis looked at this. So JAMA published an article on cranberry products and prevention of urinary tract infection. So the question they asked was, are cranberry products such as juice, tablets, capsules, and syrup associated with prevention of urinary tract infections compared with placebo or other treatments? And they reviewed a lot of different studies, and the conclusion that they came up with was that cranberry products are not associated with prevention of UTIs. However, they acknowledged that lack of association of cranberry products with a reduced incidence of UTIs in clinical trials may be due to lack of participant adherence, lack of sufficient active ingredient in the cranberry products, or lack of sufficient statistical power. So that means a lot of these studies didn't have enough patients in them. If they did have enough patients, maybe the patients weren't adherent, and also because this is an over-the-counter product, they're not regulated as much. So different brands, for example, can have different cranberry content, so it's not equivalent. So if you're doing studies across different places, or actually if you're comparing studies, then depending on what product they use, they may be given a different content of cranberry. So cranberry, do they really work? There is newer data that was published in JAMA. And they actually looked at the effect of cranberry capsules on bacteriuria plus pyuria among older women in nursing homes. And they wanted to test the effect of 2 oral cranberry capsules once a day on presence of bacteriuria plus pyuria among women residing in nursing homes. I posted this article, and I let you read this article and decide for yourself what they found. We have another Azo product over the counters, which is actually phenazopyridine. So be very careful when you hear the word azo. You have to be careful. Are they talking about cranberry, or are they referring to phenazopyridine? And some of them are actually a combination of cranberry and phenazopyridine. So it's actually a urinary analgesic for symptomatic relief of pain, burning, urgency, and frequency. So remember, these are the symptoms of urinary tract infection. So a lot of patients who get these symptoms, instead of going to the doctor, they will come to the pharmacy to try to get the azo, and often time they will come to the pharmacist to ask for recommendation to see which azo product to take, and that's the opportunity for the pharmacist to realize that this patient has a UTI. You can send them to, if you think it's cystitis, you can recommend the patients to go to their primary care physician, or if you realize that the patient has fever or flank pain, it's a more severe infection like pyelonephritis, and you can recommend them to go to an urgent care clinic. Now, this product doesn't have antibiotic activity. It's just an analgesic, so the dose it's recommended to take 2 tablets by mouth 3 times a day after meals, up to 2 days. So they say up to 2 days because if you told the patient to go to their primary care physician and they received, let's say, Nitrofurantoin, these symptoms will be gone like within the first day once you take Nitrofurantoin. So if you really have these symptoms beyond day 2 and they're still taking azo, that's a more that's concerning. So they should stop at day 2 so that if there are these symptoms present, you would know about it, so you can send them back to the doctor or an urgent care clinic. Now, this can cause headache, dizziness, or stomach cramps. And it does contain a dye that turns the urine a reddish orange color. So it's important to consult the patient about this, because if they do see, imagine if they're having these symptoms of pain, burning, and if they're taking this and their urine is suddenly red, they may think that there's a more severe underlying cause to it. They may think it's blood.
Okay, I'm here at my local CVS. Let's see where the pharmacy is. Okay, let's see. Here are the azo products. There's one for urinary tract infection test. There's one for urinary tract, urinary pain relief. There is, so the urinary pain relief has phenazopyridine in it. That concludes this presentation.